Hospital Network. Let's get started. Good afternoon. I'm Hélio Primo. I'm a director and coordinator at the Hospital Casa chain of hospitals. I'd like to thank FIS for the invitation. I'd also like to thank Dr. Alfredo Guarisch for his presence. He's an oncological surgeon at the Casa Hospital in the door chain of hospitals, and Dr. Fernando, Paragó, a medical director. The WHO defines patient safety as the absence or reduction to acceptable levels of the risk of undergoing unnecessary damage during any health-related treatment. In 1969, there was a report issued by the Institute of Medicine of the United States that concluded that the specialized services were not free of failures, and that there was a high probability of causing adverse effects. To reduce damages related to healthcare, the developed countries have concentrated their activities on citizens, especially starting on the 21st century. All of the modernization strategies should focus on improving healthcare. In that context, patient safety is one key component of medical services. And now I will give the floor to Professor Alfredo. Thank you, Hélio, and I'd like to thank Paragó and the Casa hospitals. Thank you for the invitation. This is undoubtedly the most important management congress we have in Brazil in the health sector. Safety is a gap between two accidents. There's accident A, accident B, and safety is a safe space between them. I spent several years in the Brazilian Air Force, where I had the opportunity and the privilege to interact with pilots. And we worked with one tool that's widely used in the aviation market. And you're probably wondering, what about this famous singer that just passed away in an accident? How can you explain that and say that it's a safe activity? Well, the first thing is we don't know the cause of that accident. It usually takes something between 6 months and 12 months to find out the causes of an accident. But if you look at the number of accidents that occur in aviation, and the number of people that resort to healthcare services, it's a huge difference. It's much safer to go on board of a plane than being hospitalized for any procedure. In the administration sector, like ours, what can we do to improve patient safety? Paragó is doing a great job, a very interesting work in the healthcare system, and we'll try to summarize this so that in the end, we have some time to discuss and exchange ideas. What we did during all of these years was, we developed accreditation systems and a series of very important measures, but nothing is better than training people technically with realistic simulations, and especially working as a team. The healthcare system has a huge difficulty in working as a team. The rotation that these professionals go through is extremely high. nursing technicians represent from 80 to 90% of all of the workforce in the healthcare system. And it's very, very rare to find professionals that have remained in the profession for longer than 15 years because they simply can't stand. The salaries are low and there's an extremely high pressure. And we have to find solutions for that. And that depends on administration. And healthcare is a process that involves many people. Who's the captain in a surgery room? I don't know if it's the surgeon, the anesthesiologist, or the assistant. So what we're doing in terms of using aviation tools and applying them to the healthcare system is to apply them to a setting, the healthcare setting, which is extremely different from that of aviation. The number of adverse events that occur with a hospitalized patient is huge. If you go to a hospital, you'll see that there are many abnormalities happening, and the huge majority of those abnormalities will not lead to anything. And since that's the case, many people think that there's been no mistake, which is different from what is right, which is totally different from damage. When a patient falls and breaks their leg, or if there's an infection that's completely avoidable, because you've left a vesical catheter for longer than you had to in an elective surgery, that makes everything much more expensive. So investing in safety should be our number one priority. The Brazilian Air Force works with the Flight Safety Department, and that's the same thing in the airlines. And you in the Medicine Central have created that possibility for hospitals. And the vast majority of hospitals in Brazil do not have a safety hub, which is a mandatory tool, as well as notifying adverse events. We have around 300 abnormalities, and we need 30 accidents to have a severe lesion. If we studied the 300 accidents where you have no loss of life or loss of material, it would be much cheaper, and we would avoid the 29 very severe accidents or a fatality. And that has to be changed. In aviation, starting in 1977, after the Tenerife accident, they started thinking about a tool called Cockpit Resource Management, or CRM. Now it's called Company Resource Management. And that tool discusses communications, interpersonal relations, decision-making processes, error management. All of the factors that occur in the aviation setting are the same factors that occur in a medical setting. We gave training, and Paragó was one of our initial collaborators. And we've trained almost 2,000 people in both civilians and military personnel. We discuss safety culture. We do not discuss the culture of the organization. A training given in the Air Force, for instance, where I stayed for 15 years, it's a different hospital than the Air Force hospital. And the course that I gave in the Navy is different as well. That applies to public hospitals, which are different, as well as private hospitals. But the safety culture is the same. We cannot change it. So we tend to do copy and paste, thinking that you can buy a product as a package, but that will not work. So that training has to be customized. And another important thing is that we're having a unique opportunity. We're currently giving that training in the medical school of Soros and the Federal University of Rio de Janeiro. And that's been a fantastic experience since the beginning. Medical students have this exposure, but hospital training is multidisciplinary. So we need pharmacists, administrative personnel. We have to train the team, which does not equate to giving lectures. It's a slow process that has to be rectified. There's no use doing this now and only doing it again 10 years from today. And another thing, which is fundamental, is that we also have to have the role of a clinical director of the hospital, and that's really well defined, and that's a unique person in that process as a whole. So this is what I wanted to say, and this is a summary of what we believe to be the one of the several tools out there to improve safety and to mitigate mistakes. One thing are the mistakes, and a different thing is damage. You can do something wrong, and simply damage will go unnoticed, and people may think that there's been no mistake. Thank you very much for inviting me. Thank you.
Thank you. My name is Fernando Paragó, Dr. Fernando Paragó. Yes, good afternoon. I wanted to thank you for the opportunity to be here participating at FIS Week. Rede, Casa, Dr. Alfredo, thank you for the invitation. It is an honor to speak a little bit about our experience. And in the practice of a manager that works in an institution, it's a nonprofit organization that manages hospitals in different ways. We have our own hospitals, we have third-party hospitals in 11 Brazilian states. So we have different cultures in our network, and we need to establish safety standards so that the health organizations and institutions can act safely. As Dr. Hélio said in the beginning, there was a discussion earlier in the century about mistakes, and we've learned a lot in the last 20 or 21 years. And we were supported by the aviation industry. I did a lot of study about that, and I learned a lot with Dr. Alfredo on how these models of risk activities, such as aviation, and we could also mention the oil industry with oil drilling platforms. Today, we have platforms to assess adverse events that comes from what was designed after a fire incident in a British oil platform. But we are a different industry, of course. The variability in our professional activity in health organizations is greater than in nuclear industry, oil industry. And these variations, to an extent, they ensure results somehow. There is a writer who writes about strategies for the safety of patients in real time. I've blanked about his name, but in a minute I'll remember. Well, variations can be necessary for health institutions because they ensure results. Oftentimes we look at something that went wrong. We had 10 events, one went wrong. And the 9 that went right, they had variations, but still they went right. So it's important to see what are the variations and what variations take the favorable outcomes and how we can act so that we are not, we don't have our arms tied for our professional activity. I was recently in a flight to Curitiba, and my flight was at 10 to 7. And we had boarded already to this flight. And there is a safety procedure, of course, for the aircraft, and they detected some non-conformity, and the flight was canceled. I had a very important meeting. I had to sign some papers, and there was nothing I could do. The flight was canceled. In health services, it might be different. We have a patient who comes to the emergency room. They need surgery, for instance, an emergency surgery. To have their vital signs, they need resuscitation, but surgery has to be done anyway. And this ability to be able to variate is important for the health system so that we can keep on providing positive results. This has to do with practical matters. We've evolved a lot with recent legislation, 529. It came about only in 2013, and it's our legal framework to care for our patients. We have protocols. Dr. Alfredo drew our attention to that, but it's much more common today that we manage hospitals, and these hospitals have their own protocols, their safety protocols, protocols for patients, systems for notifications and alerts so that we can communicate about adverse events. Also, this legislation states that there should be support for institutions to implement their patient safety actions. And I think that in this legislation, we need to move forward in terms of training, I would say. So I'm very glad to hear that, now in medical schools, in the syllabus, you are discussing the possibility of teaching risk management for students, medical students. We have some hospitals that are also medical schools, and our professionals, they have no idea of the risks involved in their activities. So just as pilots face this situation, aircraft pilots, they didn't face the situations before, they think that it's normal after a 24-hour shift. They think that they're going to have the same reasoning capacity. They have not been trained to understand the risks of the activities that they perform. And I think that this is something we still have to work on. It's a weak spot, and we need to evolve in this area. There's also another important topic that has been mentioned before. How can I approach safety in my health institution or organization? How do I treat safety? Well, of course, talking about patient safety, it's a trendy term now. We have many events about this topic. Many people have a degree in risk management and health, but how do we manage our networks? How do we manage our institutions in terms of health? As Dr. Alfredo Guarisch said, each different institution has a different culture, but the safety culture is one single culture. There are values that are completely attached to any safety culture, and they have to exist in all institutions. How can we do that? How can we make this happen? Currently, when we see many fusions, we have a small hospital. It used to be an individual, a standalone hospital, and they were doing fine. And then a large hospital network acquires this hospital. How do we make this integration between health protocols? We have to take advantage of the embryos, quote unquote, existing in institutions. We have to take advantage of that. And how do we work with that? How do we measure how we are moving forward with our safety culture? Well, currently there is a form of safety measures. There is a survey, actually several surveys, but the most prevalent one is the hospital survey on patient safety and culture, which brings us different dimensions and information that we need to work, identifying which values are present or not in the culture of that specific institution, and what do we need to embed in that institution. But we have to be careful not to lead to distortions. We know that it's complicated to talk about mistakes. If I speak about mistakes before a training, such as the one Dr. Alfredo is conducting, we might not reach the expected results from the medical staff and from the manager. The manager might understand that he has committed a flaw, and they might want to hide it. It's not uncommon to see in hospitals managers that require us not to notify. No, please do not notify this. Otherwise, my boss is going to see this as negative in terms of my performance as a director, as a manager. So let's not register the incident. And that person in that case clearly was not trained to work with these topics. So if we rush too much, if we have a cookie cutter receipt, and if we push our own model and I say, no, my network is doing this and not elsewhere, well, it might not necessarily work for safety. So it's really important to look carefully at this subject to ensure safety in the system as a whole. And a last comment I'd like to make is about the response given from society to mistakes in the health system. We have our councils, the Federal Board of Medicine or the Federal Council, and we have also councils for other medical areas and professions. They still lead these cases oftentimes the regional council, and we work with different regional councils in Paraná, in São Paulo, and different Brazilian states, we see that we still don't have a common understanding about the importance of looking at different processes behind eventual flaws. The legal system, on the other hand, oftentimes does not help in developing a positive culture in health systems. I'm going to mention the case of the girl that received Vaseline. There were two vials, exactly identical. One was a hydrating solution. One vial had Vaseline. The label was wrong, and it was printed. They were in the same cabinet, so that was a mistake. You know, someone made a mistake, and someone gave her Vaseline. And what did the legal system did for this intravenous Vaseline application? Well, the family went to court, and damage and mistakes are different things. When there's damage, the legal system should intervene so that there's compensation for the damage. The nurse received an accusation of homicide, and I might have grabbed the wrong vial myself, you know, because they were identical, the labels were identical. So there was a mistake, there was a flaw in the system that led to that. And after this case, the system did not improve. So the legal system, if we have these arbitration chambers, arbitration courts that are mediators in these situations, we have insurance companies and compensation is paid, like in the aviation industry. We compensate the families, and they have to be compensated. But how are we going to improve safety? Is it accusing someone of homicide? Or should we maybe blame the institution as a whole? You know, the institution should adjust its conduct. Wouldn't that be a better outcome? And the press, I would say, the media. The media could talk about adverse events just like they do in the aviation event. We've recently had an air crash with a famous Brazilian singer. No one has blamed the pilot so far. All major networks, CNN, Global Television, all networks are clear. They say we need to investigate the causes of the accident. Of course, they give relevant information. If the pilot had a license to fly, if the aircraft had a license to fly. And the goal is to stop accidents like that to happen again. So society and the press, they should face adverse events in the health industry the same way. I guess that was my overview about the difficulties that we face. We don't have a lot of time, but I'm available for the Q&A session. Thank you. Thank you, Fernando Paragó, for your brilliant explanation. Safety is key for the good situation, both in the private and public health system. So thank you very much for your explanations. We will have now a Q&A session. May I add a comment? Yes, of course. There's something interesting that I wanted to mention. It is not exactly clear what is the role that people play in the system. When Mr. Paragó says that some managers have difficulties in discussing mistake because of the reputation, of the reputational damage that might cause, they are making a serious mistake. Making a liver transplant or a heart transplant, it's undisputable that there is inherent risk. It's different from doing a C-section, of course, but people can pass over in both surgeries, although one of them has a lower mortality level. But any human activity has or involves the possibility of human flaw. On the other hand, we see a concern with using electronic medical records and using processes as if we were factories. This is excellent for well-defined processes. I would say clinical exam labs, using AI for imaging exams. I am sure that this is going to be an amazing contribution. But we still need human beings to feed these systems and to train these AI systems. So the technology has a lot to offer. And I think that electronic records, medical records, are a challenge. They are poorly conceived. In general terms, they have many advantages, but I think we still lack what we need, which is to obtain data connected to safety. And what can we learn from possible mistakes? Also, institutions have a lot of difficulty in discussing among themselves, discussing their problems among themselves. We need more space and more discussion areas. I'm doing this with Rede Casa and Rede, 2 hospital networks. So this is a completely different work when compared to São Vicente Clinic. And it's different from the new hospitals of Rede Casa. Different institutions have different cultures, even within the same network of health institutions. Each one has their specificities. So safety needs owners. Fernando Paragó, Mr. Paragó, talked about the low level of involvement of physicians concerning safety. And I think that nursing is way ahead of physicians, pharmaceutical sector, they're much more focused on safety than physicians. And I think that we always discuss, we don't discuss a mistake in assistance or in services. We always talk about malpractice, which is a problem of terminology. Good health professionals that make a mistake, the life of that professional comes to an end. A piece of that person also dies. So we have to protect the second victim, which is the professional that made a mistake. As Paragó mentioned, we have the Vaseline case, and then we had a case of coffee and milk. All these were mistakes made by nurses, but they are tagged as medical malpractice. There is no medicine with physicians alone, but there's no medicine without physicians. And it's great to have this opportunity to warn. I hope that we have several managers, health managers, here with us, and look inside. We have a lot of talent inside, and it can help us to develop this process. Of course, we can search for outsourced support. This is normal, but we need people we need in-house people. In 3 months, if we don't have an accident, something's wrong. There is always a possibility of a mistake. It's impossible to spend 10 days in a hospital after a surgery and everything being 100% perfect. There's always a small thing, and with the small thing, there's no damage. But that small thing might be the grandparent or the parent of a fatal accident in the following month. Yes, you were saying very important things. You really summarized what we said. René Malbert was the author of the book, I was trying to remember. And he says that it's, it's different if you bring inside the health system the investigation of mistakes or malpractice and control practices that will decrease the risk. Oftentimes, it's almost impossible to do a different activity because there are many bureaucratic obstacles, and then the professional, the health professional cannot perform his or her activity correctly. And as I said, it's different from an aircraft in which you just cancel a flight. Oftentimes, an emergency surgery has to happen no matter the conditions. Regarding what Dr. Alfredo Guarisch said, and I wanted to highlight that, we are talking about non-intentional flaws. And this is very different from a criminal action or from a breach in legislation. No one supports that. We have the fair culture, what we call the fair culture, and it has specific criteria. Does this person deserve to be held liable, accountable, or is this the flaw from a whole system that was poorly designed? That's a question that we have to ask ourselves every single time, and we have criteria to answer these questions. Was the person properly trained? Were they constantly trained? Is there a procedure in place? Was there a pressure time involved? Was there enough people? Or is this person maybe doing double shifts? This has to be designed to protect health professionals and also to hold them accountable when there is some breach, intentional breach in legislation, and when someone needs to be held accountable. We have to remove rotten apples, of course. And Paragó, those of you who have, these very different cultures within your system, I've been following up on your work. Can you tell us a little bit about your experience doing that? Because the DOOR network of hospitals is a very challenging example. They have almost 70 hospitals in different regions. Now we have Rede Casa also with 11 hospitals. It's a different challenge. How can we work with these different cultures within the same network? Yes, as you said at the beginning of your explanation, we need to respect local specificities. Oftentimes we have been working for more years in safety, and we think we're going to get to a new hospital and do everything the same. This is a mistake. It's a very serious mistake. First, we need to get to these new hospitals and institutions and understand the culture of that institution. What do they already have in place? What embryos, quote unquote, in terms of patient safety and quality they already have? Their internal team, they probably have professionals who know the institution. Well, let's use their knowledge. Let's use this team. And we also should identify using well-established tools. We have an auditing tool that we use in our institution that is capable of running a diagnosis of quality processes for patients. And we have quality and safety surveys as well. What values of the safety survey are in place? What values should be developed? What existing values are positive? This is very interesting. We can even use these positive values into other hospitals of the network, because a new hospital that was recently acquired might have a process that is better than the one we currently have. On the other hand, we might say, well, maybe communication has to be improved. People are afraid of reporting on incidents. Do you really understand what is the role of safety in your institution? It's not a cookie cutter recipe, as you said. We need to be humble. We need to listen and understand that there are different cultures. And it's not because they think differently that they are worse. But it's important to know, where do we want to go and what are the values that lack in that specific culture? That's how we've been able to evolve with safety. We currently are the nonprofit entity that accredits the largest number of hospitals in Brazil. So we are capable of evolving with this process in many institutions. You mentioned accreditation. Hélio, I'm sorry if you wanted to say something. Do you think that accreditation is key? I don't think it's essential, but here in our institution, I like to say that my mom, and you know her, my mom thinks I'm the best surgeon in the world. That's what she thinks, but I'm not. Dr. Alfredo Guarisch is certainly a better surgeon than I am. I know I'm not the best surgeon. My mom thinks I am. So we look at accreditation as a person that is not our mom, and she's assessing our way of working. Of course, we have to look for serious and earnest institutions that are capable of doing this assessment. We do these discussions with our accrediting institutions. We always require seasoned professionals. We know the professionals, so we know who has the right vision. I want them to look at our institutions and say, what is wrong here that I'm not seeing? And how can I improve as a surgeon? Please give me a positive criticism so that I can improve. So in that sense, I believe that accreditation can be a fundamental tool. But I agree with your mom, I have to say, you are an excellent surgeon. Yes, Paragó, you mentioned something really important. Accreditation is indeed a very important tool that has to be fostered. However, accreditation does not end when you receive the certificate and hang it in the wall. Yes, that's when everything begins, actually. That's the beginning of the process. So during the accreditation period, the hospital, is in a boiling point, and then when the accreditation process finishes, it's as if people forget everything. I've been working for many years, and the special operations police forces, they are not accredited. So we need, and they do an excellent job anyway. Accreditation organizations, they are responsible. If an accreditation agency tells you you are accredited, they are giving you a green light. And medical schools should also be responsible by the professionals that they are placing in the labor market. As physicians, we have to discuss the possibility of having a test for physicians to join. We've been having several legal cases, several claims, and that's a response from society of the lack of the inability to meet fair requests. When we need to apologize, when we need to do crisis management to explain something that is unexplainable, we learn and we grow. It's like teaching our children. If we are not tough with our children, they will not learn the right lessons. So institutions need safety policies and protocols, and we have to separate mistakes from breaches, from crimes. We cannot accept breaches of legislation. When that happens, the institution and the managers have to act. In large hospitals with several services, a patient comes through the emergency unit, they go through x-ray, they go to surgery, and then they go to intensive care, and things get complicated. They go back to surgery, then they go back to intensive care, and then they are admitted out of the hospital and they die. And even in hospitals, we have cultures, different cultures within the same hospital. And this is something that scares us. When we think about something that is systemic internally, oftentimes we don't have what we need. Some hospitals are doing this very seriously, which is clinical meetings where complications are discussed, and there is real interest in having the appropriate environment. No conversations in the hall, no conversations in the cafeteria, serious scientific discussion. And we would all benefit from that. From a management perspective, what is the cost of a patient having a lesion because he fell down from the bed? It's much more expensive than training a professional. Yes, Dr. Hélio, I'm sorry, I think our time is up. Yes, we don't have any additional questions, and I think we are out of time for this panel. Hélio, you work at the cancer hospital, and it's not very simple to deal with the everyday of our colleagues, everyday routine of our colleagues, but we are working hard, and I think that all hospitals should try to develop leaders that will spearhead this process. Otherwise we will not move forward in terms of safety. And I think that safety being one of the items in important symposiums like this one will help us to improve and to learn. There's a word that I learned the other day. Safety is the cheapest item when it's second-hand. When I learn safety with my own mistakes, it's much more expensive than when I learn from mistakes that happen next door. And we need to have a clear, honest, and friendly way to share our mistakes in an appropriate manner. We should discuss our flaws and our mistakes so that we can contribute to the most beautiful thing in the face of the earth, which is one human being caring for another human being. There's nothing more beautiful than a human being caring for another. Physicians, nurses, therapists, we are carers. We care for people. That's what we do. That's our job. We care for people who are sick and not the other way around. Oftentimes we treat diseases and we forget to treat patients. But I think we should be careful, care for people. Thank you, Mr. Paragó and Hélio, for the invitation. It was a pleasure to be here with you. It's such an important panel. Thank you, Alfredo Guarisch, and thank you, Fernando.